Very good. Excellent. طبعا, thank you very much for coming tonight. It's an honor and a pleasure to have Dr. Ahmad Al Badr with us here for this lecture. Ahmad Al Badr أولا أستاذي ودرسني وعلمني I'm very happy that we're sharing a lot of memories together. Just a second. Yeah, so it's a pleasure and an honor to introduce Dr. Ahmad Al Badr. يعني الكل ما شاء الله بيعرف دكتور أحمد وأستاذنا جميعا. Dr. Ahmad Al Badr, he's a consultant urogynecologist. He's the first consultant urogynecology in Saudi Arabia and reconstructive surgeon. He's an executive director of research at King Fahd Medical City. We have very nice, we're going to have a very nice lecture inshallah today by Dr. Ahmad. I'm very eager to attend it, and I'm always fond of attending lectures of Dr. Ahmad. So welcome, Dr. Ahmad. Thank you very much for joining us, and the floor is yours. Please share your screen. You are inshallah ready.
Sure. Shukran jazeelan. Thank you so much for the nice introduction. Haytham, you made me feel a bit older than what I feel, but
no, you're not. You're not. It's Ustaz.
Allah yasalak. No, you're a colleague and a friend. Let's yeah. So thank you so much for the nice introduction. So today I'm going to be talking about urinary incontinence in general. It's an overview and of urinary incontinence, and I'm going to be touching on some of the issues in some details. The topic is a bit long. I'm figuring out how to
share the screen.
There it is. I found it. Okay.
Yeah.
I found it, and then I just want to do the. I'd like to thank you for inviting me. I'd like to thank the Medical Education Without Boundaries for this initiatives. I think it's really great having it at this time.
Excellent.
Think it's very useful. Thank you so much, Shaitan, and thanks for all your team.
Very much. Excellent. Just the borders, لو تظبط البوردرز ممكن شوية.
Okay. There.
Yeah.
Like
excellent. Good? Yeah. Everything is okay now. Very
okay.
Good. Thank you very much.
Excellent. Come on. Okay, so Bismillah, we'll start. So today we're going to be talking about urinary incontinence in females specifically. And I have nothing to disclose. This is the outline of my presentation, definition, how the scope of the problem, types, risk factors, and then quick touch on evaluation, treatments, and then we come to the conclusion. The way I look at it, I'm thinking of maybe giving the presentation and then leaving questions and answers to the end. That's what I think. But if there are any pressing questions,
yeah, I think I agree with you. So let's leave the lectures for the end. Sorry, the questions for the end. So yeah, so feel free to.
Okay, excellent. Okay, so urinary incontinence. What is urinary incontinence? So urinary incontinence is any leakage, involuntary leakage of urine. This is the latest definition. There has been transformation of definitions. Now it's just any complaint of involuntary leakage of urine. It's a problem that affects women. It affects their, apart from affecting their psychological, apart from being a depressive problem, causes women to be isolated, embarrassed. They avoid activities, affects their marital relationship, causes skin changes, skin problems locally, and in the Muslim community, it interferes with prayers and purity, as you would know. Now, urinary incontinence in general, it is estimated to be around, as you can see here, I don't know if you can see the mouse, it's around 27.6% international prevalence. This is a study we've done in 2003, where we looked at prevalence studies around the world, and the average was around, so let's say 28% in general. And as you can see, the prevalence goes up with age. Now, most of those women, it seems that the incontinence is sort of somewhere between, mostly in the mild, moderate range, but some of them are in the severe range, and according to study where the incontinence was done. This slide shows you the lifetime risk of having stress incontinence or pelvic prolapse surgery with age. And as you can see here, the stress incontinence surgery is the one in red, prolapse is in, I think this is purple, and then combined is green. So this is the lifetime risk of having surgery. It goes up with age. Now, what is the prevalence of urinary incontinence in Saudi? We recently conducted, not recently, it has been 2015, we've conducted a national survey around the 13 provinces in Saudi, where we sent our research assistants to those regions. They've interviewed more than 2,000 women all over more than 70 primary hair care centers. Those women are presenting to the primary hair care centers for a reason other than their gynecologic complaint. So they're accompanying someone else, they're there for a dental reason or something general. And with that interview, we have found that the prevalence of urinary incontinence in Saudi to be around 36.3%. So this prevalence is higher than what is quoted for as international figure. The international figure is around 28, as I mentioned, and here with 36% prevalence of urinary incontinence in Saudi. Now, this is the largest cross-sectional study from Saudi, and this is probably the closest to reality. As you can see, this from the second line, the prevalence of overactive bladder is around 50% of women. And then around 10% are using napkins for incontinence, meaning that incontinence is severe or quite frequent. And fecal incontinence is around 8%. Now, this study we're in the final stage of analysis, and hopefully it's going to be published quite soon. Now, let me just talk to you very quickly about the continence mechanisms that prevents urinary leakage in women. So there are several mechanisms that prevent leakage. It's not just the urethra and urethral sphincter closing, no. Well, that's one thing, is the urethra by itself closing and preventing leakage by a couple of mechanisms, as a matter of fact. So there's the external urethral sphincter, which is usually under state of contraction. There is the internal sphincter, which there's a tone continuous all the time. And as well, there's what's called coaptation. Coaptation is stickiness of the urethral mucosa. And that's because of the increased vasculature around the urethral mucosa. It helps the stickiness of the mucosa, of the urethral mucosa. So the urethral mucosa the walls touch each other. And with that, it prevents leakage of even a drop of urine cannot pass, subhanAllah. So that's the urethral part. Then the bladder part is in the continence state. Now, just a quick, again, a reminder, when we're talking about continence, it means that that's in the state where someone is trying to be continent and is trying to not leak urine. It means that when she is not in the toilet, anytime she's not in the bathroom trying to urinate. So these are the urethral mechanisms. And then we have the bladder mechanism, whereby the bladder muscle relaxes, and the bladder muscle, when it relaxes, it also helps in preventing incontinence. The trigone, there are some muscles, those muscles also on the stage of contraction. they help also in prevention of leakage of urine. There are two other mechanisms as well. There is the levator ani muscles, which are here. And as you know, they do provide as a hammock. They go from the pubic bone, wrap all the way around and come back. So they pull, and so they're usually in a state of contraction, whereby when they're contracting, they pull everything forward and push the genital hiatus, including the vagina, the urethra, and the rectum, against the pubic bone, and with that, they prevent leakage of urine. So the pressure against the bone, as well as the increase in the uretrovesical junction angle, and that helps also in the continence mechanism. So there are several mechanisms. It's not just the urethra is contracting. So there are ligaments holding stuff in its place. There are bones that are there, which ligaments and muscles are attached to. So there are many mechanisms that help in prevention of leakage or in the continence mechanism. And this is just a slide showing the quick anatomy of the bladder and urethra. Now, let's talk about the types of urinary incontinence. It's important to understand the types of incontinence, because to be able to treat, you have to be able to diagnose properly. If you do not diagnose properly, you won't be able to treat properly. Now, previously, we used to say that stress incontinence is number one, the most common type, and we used to divide it into two types: urethral hypermobility or intrinsic sphincter deficiency. Now, you might still see those in textbooks dividing stress incontinence into those two subdivisions. Those two subdivisions, hypermobility meaning that the uretrovesical junction ligaments has been disturbed because of delivery. Intrinsic sphincter deficiency basically means that the muscle itself is weak. Nowadays, we try to avoid using those terms, and we stick to more of mild or severe stress incontinence, whereby we denote urethral hypermobility to be the milder form, and intrinsic sphincter deficiency is the more severe form of stress incontinence. And sorry for this video, but for the slide, that this is what stress incontinence is about. Then we come to urgency urinary incontinence, which is one of the second most common type of incontinence. And urgency urinary incontinence is basically leakage of urine before reaching the washroom, or urinary incontinence which is preceded by this urgency. So urgency urinary incontinence, when it's there, that's part of what we now call overactive bladder. Overactive bladder is basically urgency frequency with or without urgency incontinence. So overactive bladder, there's overactive bladder wet, or which is with urgency urinary incontinence, or overactive bladder dry, which means that there's frequency urgency but no urgency incontinence. But so that's you need to understand, so you don't confuse terms together. So urgency incontinence, we meaning that there is the incontinence which is preceded by urgency, and in this case it is part of overactive bladder syndrome. So there is also the mixed type of urinary incontinence, which is composed of both stress and urgency incontinence, and it is probably the most common type of incontinence, which is have a combination of both stress and urgency urinary incontinence. Now, when we're talking here about types, we're really talking about we're talking about what the final diagnosis is, because those incontinence could be a symptom, could be a sign that you would see, or it could be diagnosis. Here we're talking in general about it as a diagnosis. Another type is the overflow incontinence. Overflow incontinence basically happens because of the overdistension of the bladder, either because of bladder outlet obstruction or because of the muscle weakness of the detrusor muscle. So the detrusor muscle does not contract, so it just keeps filling, and then with movement there will be leakage of urine through the urethra. And usually if the bladder usually fills to a point where it overcomes the pressure, where the pressure, at least pressure would be around the urethral opening. So the bladder usually does not rupture. So it usually leaks through the urethra when there is over distension of the bladder. So usually those people present with leakage on movement when they move. So it looks like, or it sounds like stress incontinence. So they're sitting and stand up and they would leak small amount, and then they would cough and they would leak. So it sounds like stress incontinence. However, usually they do not feel the bladder. They don't have the sensation of the bladder. So this is another kind of incontinence. So it sounds like stress incontinence, but it's completely different. So the treatment is exactly opposite of treatment for stress incontinence. So it's very important to differentiate. And then there are the extraurethral causes of urinary incontinence. Again, extraurinary, we mean about fistulae. Fistulae is fistula or abnormal communication between the bladder and the vagina. Could be between the bladder and the vagina, bladder, bladder and cervix, or bladder and the uterus, or it could be urethrovaginal fistula. Now, fistula, usually there's a continuous leakage of urine. However, there are some times when the fistula is quite high in the bladder, where they present something similar to stress incontinence. So when they cough, they would leak, and they don't leak all the time. And that happens when there's a fistula which is high up after, for instance, a cesarean section, where there's a cervical fistula or hypocervical fistula. So again, it's really important to try to understand and differentiate between the types before starting a treatment. Here, it's important to know the psychovaginal fistula. Usually, it is after a delivery or a cesarean. So if something happens immediately after, then you have to keep this in mind that that is possible. And there are the reversible causes of incontinence, such as urinary tract infection being the most common. Usually, they present with urgency urinary incontinence or worsening of a mild urinary incontinence, or they have urgency without incontinence and then it becomes incontinence for a short period of time, then that could be urinary tract infection. So urinary tract infection, diuretics, some medications, impacted stools in the elderly, a large amount of diuretics, those are all causes of reversible cause of urinary incontinence that we usually need to try to diagnose first. So if we find them, then we treat them. Then patient is much happier. And so this slide shows the abbreviation for the reversible cause of urinary incontinence. The abbreviation is diapers. So delirium, infection, atrophic vaginitis, pharmaceuticals, psychological problems, excessive urine output, restricted mobility, and stool infection. Now, let's switch gears to risk factors for urinary incontinence. Now, there are basic two categories. I like to categorize things to remind myself. So here, if we say risk factor incontinence, I'd like to say there are inherited or genetic causes, and then there are external or acquired factors. So when we talk about inherited genetic factors, we talk about race. Caucasian having higher risk, Black having lower risk, anatomical differences. So a gynecoloid pelvis, for instance, is more likely to get incontinence rather than an anthropoid or android pelvis, because the android or anthropoid is more tight pelvis, so they're less likely to have incontinence. Then another risk factor is connective tissue. So there are connective tissue diseases that we know of, like Ehlers-Danlos syndrome, like Marfan, which is there's hyper stretchability of the joints and ligaments. But so those ladies have high risk of incontinence. However, there are connective tissue diseases that we're not aware of. So there are families that have higher risk of urinary incontinence. We don't know why, but those probably have some connective tissue diseases. We see some ladies who have prolapse at younger age with having one child or no child, and you find that the stretchability of their cervix that comes down to you. So those people have some connective tissue disease that becomes hyperstretchable, they're more likely to get prolapse and incontinence. Then neurological abnormalities, spina bifida is a classical example. Now we switch to external causes of urinary incontinence. Aging, that is one. Childbirth and pregnancy is the most important cause or risk factors for incontinence in general. So it has the higher risk. When you look at any study, childbirth is the higher risk. Of course, vaginal childbirth is a higher risk. However, even cesarean section is a risk factor. So pregnancy by itself is considered the risk factor. However, vaginal birth gives higher risk than cesarean section. Then there's pelvic surgery, chronic increased intra-abdominal pressure, such as fibroid or obesity, people with ascites, liver disease, for instance, all increases the risk. Chronic constipation, chronic cough as well. It's known risk factors as well. This slide, I'm sure a lot of you have seen it before, just shows you the importance of the significance of childbirth passing through the birth canal. And as you can see, it stretches the vaginal canal, stretches muscles, ligaments, and tears ligaments, and so on. So this just demonstrates how the risk factor of childbirth in relation to development of incontinence. And this is a study, this is our study that we've done in 2003, and we're linking the number of births, vaginal number of deliveries in general to incontinence. As you can see, the prevalence moves from, depends on how old according to the number of deliveries, and you can see it doubles from 0 to 1. But then after 1, the increase is only slight. Now, when we have somebody with incontinence, as I mentioned before, it's really important to be able to differentiate what type of incontinence she has to be able to treat. Now, if you do not know the proper diagnosis, it is best to transfer the patient to someone else or try to really understand what she has. Because treating just in general, except for very few exceptions, it is not really recommended. And I'll talk to you about what are the exception treatments that you could try in all women with incontinence. So, first part of assessing women with incontinence is patient evaluation, is history. Now, history is really important. You get around 70% of your diagnosis out of history. So if you get somebody saying, I have incontinence, and then you send them for an ultrasound without talking to them, as many of us do, you're not going to get anywhere. You're not going to diagnose her. So really, incontinence needs thorough history. You need to understand about symptoms. When does the incontinence happen? When does it happen before reaching the washroom or with cough sneeze? A lot of times patients would direct you or would not answer your question the way you ask the question. So you really need to stop and say, okay, stop. No, I'm asking the question. Do you leak before reaching the washroom or with cough, sneeze, laugh? So you need to really try to get as much as you can from their history. You need to know if there are any other associated urinary symptoms, if she had recent surgery, if she has maturia, Endometriosis, coital incontinence, and so on. Medical history, diabetes, then you need to also look at prolapse symptoms, colorectal symptoms as well. You need to screen for other pelvic floor dysfunctions as well. Medications are important, and then fluid intake is again important. Some people do drink a lot more than they should, and some people do not drink in trying to avoid the incontinence. So it's important to understand. And also you need to look into what previous investigations or therapies they've had. Sometimes they do not tell you what they had at the beginning, and unless you look into to try to avoid things that they've done instead of trying to go into investigations and therapies, and then they come to you, no, I've tried this, and I've tried that. So it's much easier that you understand from the beginning. Then quality of life measures. Quality of life measures basically are a set of questions that you ask the patient, and then it gives each question, he gives it a number, and at the end you get like a total number. With that, you get a measure of quality of life. So how much the symptoms affect her quality of life. So you're getting sort of a tangible result for incontinence. So it gives you severity of incontinence. And quality of life measures are really important in diseases which symptoms are the most part of the diagnosis, such as depression, headache. These things you cannot measure yourself, or there are no lab tests to measure. So quality of life measures are important. And there are several quality of life measures validated into Arabic that can be used. It gives you severity of incontinence. Here is, and I'll come to one of those in a moment. So where did I go? Here. Okay, so we're done with history. Then we go to physical examination. Physical examination, mobility is important. You want to see if she's on a wheelchair, if she's on using a cane, or she's walking. Sometimes they have incontinence because they cannot reach a washroom in time because they cannot walk and the toilet is far away. So there might not be a big problem of incontinence rather than mobility related. Then there's a general assessment, abdominal examination, and then lower back reflexes if there problem with sensation of feelings or sensing the bladder filling. Again, in pelvic examination, you need to look at the skin if there are changes that signifies a severity of incontinence. If someone comes with red area, which is really, it seems like it's quite irritated from incontinence, tells you that it's severe and every day. Probably need to do a new mini neurological exam, which is with that you try to see if the sensation is there on both sides and reflexes are there. Now, if they're positive, it means that the nervations are normal. If it's negative, it does not say that it's abnormal. Some people are negative by normal, but negative. So if it's positive, then it tells you that it is positive. And with part of your examination is assessment for pelvic organ prolapse as well, and teach her how to do exercises. This is the best time to do or to show someone how to do pelvic floor exercises, as well as the time to assess the strength of the pelvic floor strength, contraction strength. So there's different assessment grading systems for the strength of pelvic muscle. There's the Oxford and others. So it's one of them is from grade 0 to 4, 0 being no twitch with the contraction, 4 being the strongest. So they're different grading systems. Then you need to do the cough test with a comfortably full bladder. If the bladder is empty and you do a cough test and it's negative, well, the bladder is empty. So unless the bladder is empty and she coughs and leaks, that means that it's what we call empty cough test, and that signifies more severe stress incontinence. Now, bladder neck mobility used to be popular back in days. Well, I'm not going to say I used it because otherwise you're gonna say I'm old. So I'm going to say they used to teach us that to use it, but nowadays I don't think it needs to be done. It is used to assess for the bladder neck mobility, where you put a Q-tip in the urethra, and then you ask the patient to squeeze, and then you see the Q-tip moving up and down. Then if there is a movement, so if there's a movement of the Q-tip, there's a Q-tip inside the urethra, and then you ask her to squeeze. If the movement is above 30 degrees from the horizon, it's considered positive, and it tells you that there's hypermobility. When you know that there's hypermobility, it means that it's a milder form, and it means that birth suspension is useful in this case, whereby if it is less than 30 degrees, it means that there is no hypermobility, it means that it's a more severe stress incontinence, and it means that it needs a sling. So that's what it means in the long old days. I think you might see it here and there, read about it. So I thought I'd mention it. And then finally, rectal exam again it's quite important for rectal tone, and then you look for rectocele as well, and then you look for blood, and so on. So with history and physical examination, you put them together, and then you come up with your you come up with a preliminary differential diagnosis. And then there are a couple of investigations that needs to be done in all women with urinary incontinence. So we come down to 2 tests that needs to be done in all women. One is urinalysis, and if it's positive, then urine culture. And it's easier just to do them together, just urinalysis and culture from the start. It's very important because even if lady does not have dysuria nor frequency, urgency, very clear urgency, she might have incontinence if she, urinary tract infection. And if you treat the urinary tract infection, then she might get much better, that she would say, okay, now it's much milder, so now I'm happy. So that's one that you have to do. And the second one is post-void residual urine volume, measuring what's left inside the bladder after they urinate. And there are 2 ways to test that or to check the post-void residual. One way is by ultrasound. So there are specific scan machines that you put, and they just gives you a reading number. And then there's the ultrasound, the regular ultrasound, which is done in the radiology department by our radiologists. So they do the bladder scan with the bladder full, and they ask the lady to go to the washroom, urinate, and then come back. And then they measure post-void residual. And then so this is ultrasound, both ways are ultrasound. And then there's the catheter, the old way of after urinating, putting a catheter in, leaving it for 5 minutes, seeing how much is left, and then removing it. And that can be done when you do not have an ultrasound machine. So anything less than 50 and 100 is considered normal. Anything above 200 is considered abnormal. It means if there is high post-void residual. Somewhere in between, then it's equivocal or inadequate. Just keep in mind, sometimes you get an abnormal reading once, and then when you repeat it, it's normal. But if you get a normal reading once, then most likely it's normal, it's fine. Now, there are other more specific tests that can be done that I do in my urogynecology clinic because I have it and because I get referrals for specific situations, but it does not need to be done except in specific cases. So urolog or avoiding diary, again, that can be done, can be used by everybody. You can give it to your patient and ask them to fill up a 2 or a 3 day voiding diary, where they fill up every time they take fluids, every time they urinate, and they chart every time they leak. And if leak happens with a cough or with urgency, and how much they leaked. So with that, they come back to you, and then they hand you over the 2 or 3 pages of the voiding diary. And with that, you can make an objective assessment of how much urgency or how much incontinence they're telling you. So they're telling you something, and then you see it in writing, and then it gives you a better impression of what they're talking about. Quality of life measures, as I mentioned earlier, and this is an example of what we call the ICIQ, which we've validated in Saudi. It was translated into Arabic and we validated in Saudi. And as you can see, they fill up if there's incontinence, and then how often does it happen, and then the severity, and then at the end you get number, and the final number gives how severe that is. And this is an example of the voiding diary, and this is what we give out to our patients. So 7 o'clock in the morning to 8, so 8 to 9 every hour, and then if they went to the washroom, they take it, they've had fluid, they take, and then if they leak, they take, for the last 24 hours. So that's quality of life measure, ICIQ, as I mentioned. ICIQ stands for International Consultation of Incontinence Questionnaire. There's the IIQ-7, International Incontinence Questionnaire. There's UDI, urogenital dysfunction inventory. So there are different quality of life measures that can be used. There's PAT test that used to be done previously and not very common these days. And then there's the tampon test. Tampon test is basically a test you do to assess for fistula. So you put a tampon in, or two pieces, or you put three little pieces of cotton or tampons, and then you put some methylene blue in the bladder, or ask her to take phenazopyridine. Phenazopyridine is a medication that when someone takes it, it turns the urine orange. Or if you put methylene blue in the bladder, it turns the urine to blue. And then you put the tampons in the bladder, in the vagina, not in the bladder, in the vagina. And then you ask the patient to move around, and then you come back, and then you remove it. If you see that the lower tampon is the one which is filled, it means that it's most likely close to the urethra. So maybe it's a urethral leak, maybe meaning stress incontinence. Or if you find that the top one is the one is just full, but the lower ones are not, then it means that more likely it's a fistula. And this is one of the ways that you use to look for fistula. And then there is more advanced investigations like urine cytology, if you're worried about malignancy, if there is urgency frequency, and then your analysis showing cells and you're not sure, then cytology can help. However, it's not diagnostic completely for malignancy. Uroflow can be part of urodynamics, or it could be alone, where it just checks the flow of urine, and this is the screening tool for voiding the dysfunction, or for the voiding part. So usually combined with post-void residual to give an impression about if there is voiding dysfunction or not. Then there is urodynamics. Urodynamics is basically an investigation which measures the pressure compared to flow in the bladder, and it gives you an impression about incontinence and at the time of voiding. So it gives you an impression if with somebody during incontinence or during when she's not supposed to leak, about the bladder capacity, sensation, if there are contractions, and if there is leakage with cough. And then there's the voiding part, which shows you about the bladder pressure, and then shows you how the pressure is, and then how much is left in the bladder. So basically, urodynamics is a tool, physiologic testing for the bladder, for the physiologic function of the bladder. That's urodynamics. Urodynamics now we do not do on all patients. We only do it in select cases. So there are specific indications to do urodynamics. We do urodynamics, for instance, if we're going to do for surgery, if we tried conservative management and they fail, somebody who we give medication that's not working, somebody we've done surgery and they came back with incontinence, or somebody has severe prolapse. So prolapse is really big, more than stage 2, and then we want to do surgery, then we usually do urodynamics at the same time. So that means that urodynamics is not done on everybody, and that's important to know. So we do urodynamics. So when we get somebody in the clinic that has incontinence, it sounds like stress incontinence, so we start treatment for stress incontinence. However, if we get urgent incontinence, and it sounds like urgent incontinence, then we go for treatment for urgent incontinence without doing urodynamics. So we only do urodynamics in specific cases when conservative management does not work, or we're planning to go for surgery generally. And there are other indications, and urodynamics is a whole big topic by itself that would not allow it. I don't think we have the time to go into. Perhaps we'll give it a specific lecture by itself. And these are the specific situations where you do urodynamics. The message here I wanted to pass on is that you do not need to do urodynamics on all your patients. You can start simple treatment without doing urodynamics. You do urodynamics after you do initial assessment, and you start some treatments and they fail the initial treatments or the simple treatments, then you can go for urodynamics. So we're done with urodynamics, or we're done with investigations, and at the end we came up with the diagnosis of urinary incontinence. Now we need to go for treatment. Now here we're going to talk about treatments in general. What are the treatments available for incontinence in general? However, not all treatments are useful for all types of incontinence. So this part you really need to understand. When I talk about any specific treatment here, I'm going to say this works for this type of incontinence. So just keep this in mind. So you cannot give all types of treatment to all type of incontinence, and that's why you have to have a proper diagnosis to be able to treat properly. So to start with, let's look at conservative management for incontinence. So with the first part of the conservative management is like continence devices. So there are catheterization, for instance, or absorbent pads. And these are things that help. However, these are not real treatments. Then there are the behavioral changes and under conservative management. And behavioral management, meaning that you try to change behavior to adjust for incontinence. And this usually works for people who have urgency incontinence or overactive bladder in general. Stress incontinence, usually behavioral modification does not help very much, except for pelvic muscle strengthening exercises. So there's a part of behavioral modification is fluid management, meaning that they have to take enough fluids, or if they're over drinking, they reduce. Bladder drills meaning that they would try to train the bladder to hold more urine. So people with urgency frequency, meaning they have overactive bladder, you try to train them for the bladder to accommodate more urine, and so they can control themselves. I usually tell them, okay, so you try to ignore the bladder sensation, you try to finish the TV program that you're watching, for instance. If you're cooking, you try to finish cooking. If you really need to go to the washroom, go to the toilet. However, do not jump to the seat, brush your teeth first, put some makeup, just distract yourself, do something else. So with time, you're trying to treat the bladder to accommodate more urine. Then pelvic muscle strengthening maneuvers, and we'll come to that in details in a few minutes. In general, again, conservative management, there are pessaries that helps with incontinence, and there are pharmaceutical therapies. Pharmaceutical therapies, there are hormone replacement therapy, medication help strengthening the urethra, or medication helps with bladder, and we're going to talk about them in general. Now, there are several companies that provide diapers or absorbent pads in the market, and their products are becoming more and more available, and they're introducing new products. So meaning that continence is really there. If you go into pharmacy, you can see many shelves which are filled with continence pads. So that tells you how big the problem is. I mean, pharmacies here in Saudi, if you go to any pharmacy, just look at where they put the pads, and you can find the continence pads filled. So these are considered assisting or trying to prevent disappointment or embarrassment. However, this is not treatment for incontinence. So let's get into more details about fluid management, which we talk about it as part of therapy, so a part of behavior therapy. So avoiding caffeine, alcohol, and smoking, these are bladder irritants. So avoiding them reduce overactive bladder symptoms. So they help with women with overactive bladder. They do not help with somebody with stress incontinence. So you tell somebody with stress incontinence, avoid caffeine, while you're giving her wrong treatment, and she's not going to get better, and she's not going to be happy. So you really need to make sure that you've got the right diagnosis and then give her the right treatment. Again, you try to get the bladder to fill more. If they have nocturia, you try to get them not to drink fluid couple of hours before going to bed, and empty the bladder just before going to bed if they have nocturia. If you want to increase the bladder capacity, there is a way by trying to increase gradual the time between each void, and that's called bladder retraining, and it has been shown to improve the overactive bladder symptoms. Now, when we talk about pelvic floor physiotherapy meaning that we're strengthening the pelvic floor muscles. Studies have shown that strengthening pelvic floor muscles help most type of urinary incontinence. So this is one of the treatments that you can give to almost all types of urinary incontinence. Give them pelvic floor muscle strengthening exercises. Of course, except for fistula, it's not going to improve. But here, overactive bladder, stress incontinence, mixed incontinence, it does improve. So there is the Kegel, which was introduced by Kegel in the 50s, and it's basically contracting pelvic muscle. When we talk about Kegel, we usually say doing exercises at home, contracting the muscles a couple of times, a couple of minutes, 2-3 times a day. Very important, she should not doing during urination in the toilet. We tend to tell our patients do it during void, and this is wrong because you're giving the bladder wrong signals. So they can try it once or twice just to identify which muscle group they're using. However, should not do it during urination. Please, I get it frequently. Women coming to me and I explain this to them and I say, oh, my doctor told me that this is the best time to do it. Should not do it during urination. This is a Cochrane review, systematic review about pelvic muscle contraction, and it shows that the pelvic muscle strengthening does help a lot compared to placebo in treatment of incontinence. There are vaginal cones that are weights that are placed inside the vagina, and when they're placed inside the vagina, they contract and they go around at home and move around, and then they try to make the muscle squeeze, and with that, it helps with incontinence. Again, it helps similar to doing Kegel exercise itself. They usually, all of the pelvic floor physiotherapy need at least 6 to 8 weeks at least for the muscles to become stronger to find benefit. So doing it 2 to 3 days, not gonna help. 2 weeks, no benefit. So it needs to be at least 6 to 8 weeks. So vaginal cones is another way. There are cones, some of the clinics do sell cones, and like international shopping areas like Amazon do sell vaginal cones as well. There are the small biofeedback or stimulating machines that are placed inside the vagina that they use it at home. So they place the handle inside the vagina, and then they use the controller either to do electrical stimulation, or they contract and then they visualize the results. And these as well can be bought through international suppliers, and they have shown to be improved incontinence. There are the electrical stimulations that are done in the hospital, and there are the magnetic chairs that women sit down on chairs without taking off their clothes, with doing sessions 2 or 3 times a week per week. Again, they have shown good results with most types of incontinence. Switching gears to pessaries. There are pessaries specific to incontinence, and they've shown that they do improve incontinence. They improve mostly stress incontinence. They're not my favorite. However, studies have shown that they do improve stress incontinence. And I have patients in my clinic that have been treated by my fellow, usually by pessary, and they're happy. And basically, they don't want to have surgery, so they've tried physiotherapy and it doesn't work. So they go for pessary. Some of them are happy. Now there are pharmaceutical therapies like hormone replacement therapy, and have not shown to be very helpful for treatment of incontinence. However, except for estrogen, vaginal estrogen helps a little bit women with overactive bladder. Now there are medications strengthening the urethra. In case strengthening the urethra, meaning that stress incontinence, such as cold medication, and there have been warning on them and should not be used. Tricyclic antidepressant have some adrenergic mechanisms. So women with Mixed incontinence can use tricyclic antidepressant, however, it could cause arrhythmia, and there's a warning about women above the age of 50 should not use. There have been talk about to use duloxetine, which is an antidepressant for stress incontinence. It helps a little bit, however, not significantly over placebo. Now, medications that relax the bladder, and these are medications that we use for overactive bladder. And they're basically three categories. One is anticholinergics. Anticholinergics relax the bladder, and there's tolterodine, sulfenacin, and more recent than the others, trospium. Then there's a tricyclic antidepressant, which I just talked about. They are good for mixed incontinence. And then the most recent one is a mirabegron, which is an beta-3 adrenergic agonist. Now, most anticholinergic have the side effects of dry mouth, blurred vision, and they work in about 60–70% of women. Some use it and do not find benefit. The advantage of mirabegron is that you can combine it with one of the anticholinergics. So you try one of the anticholinergics, it doesn't work. You can add mirabegron on top of it. Unless they want to use mirabegron alone, then again, it has been shown to be effective. So it's an important addition, and it has been approved by the Saudi FDA just recently, not too long ago, in Saudi Arabia. Regarding nocturia or nocturnal enuresis, desmopressin, or it's called Menarin, it has been shown to be effective in treating nocturia and nocturnal enuresis. And there has been studies about using it daytime if somebody has urgency and you want to reduce urgency during daytime, urine incontinence daytime, but it's not an indication that we usually use. But it's one of the very good medications for nocturia and nocturnal enuresis. Just need to keep in mind that you need to check the sodium level, as it might cause hyponatremia, so you need to check it every couple of months. Now, in women with overactive bladder, which do not improve with medications, these are usually very difficult women to treat. They're not difficult women, they're difficult to treat. They are nice women. So there are two options to go for, either Botox injection inside the bladder or neuromodulation by sacral nerve remodulation or posterior nerve stimulation. Again, those people are we call refractory therapy, people who do not improve with medication. So you go to one of those therapies, their benefits are around 50–60%. They improve, and when they improve, it's like magic. So you transform their lives. So they are quite effective. Botox is one-time injection. It works for 6 months to 1 year. And then neuromodulation needs a little bit more of dealing with, but they're both quite effective. Both are details I take, and we need much longer lecture to talk about, however, I just want to touch on them. So now we switch gears to surgical management. And when we talk about surgical management, we usually talk about surgical management for treatment of stress urinary incontinence. Overactive bladder, we said conservative management, medication, and then we go for Botox or neuromodulation. Stress incontinence, we usually talk about pelvic floor exercises, weight reduction, pessaries if those do not improve, and then if not, then surgery. And surgery has very good success rate, but I'm going to talk about different surgical procedures. One of the surgical procedures is periurethral injection, where you inject some thick material around the bladder neck at the urethral muscle, and you can see the slide in the back shows the open bladder neck, and here after the injection you can see that it closed the bladder neck. So with that, it shows that it has some improvement. It has the advantage that it's minimally invasive. However, the results are not too strong, so they don't stay very long, but they're okay for about 60% over 3 years. I think in the market now, there used to be several companies. Now there's only 1 or 2 products, I think Macroplastic and another company. So we reserve it to cases where they don't want to have the proper surgery or the gold standard therapy. We can offer this. The previous gold standard is retropubic suspension, which it used to be like Birch or MMK, and we stopped using them since the introduction of TVT in around 2005, where they've been shown to be the treatment the gold standard became TVT or slings. In UK, there was a pullback of slings, and then they went back to MMK or birch. Again, those procedures can be done with open surgery or laparoscopic, and they have very good success. Well, they have good success rate. But now the gold standard is becoming really TVT or TOT, so suburethral slings, tension-free suburethral slings. Both are okay. However, new studies have shown comparing TVT and TOT, showing that in some studies that people with severe stress incontinence, that TVT has better success rate than TOT. This is fairly new information, about 2 years or so, 3 years, or maybe a bit longer. But it has become much disseminated information that retropubic TVT, which is behind the pubic bone, going beyond the pubic bone, has better success rate than the obturator sling for people with severe stress incontinence. So TVTs are becoming the standard of care and for treatment of stress urinary incontinence. Now, just before I finish, let me talk briefly about energy-based devices. Energy-based devices are either one of 3 categories, either lasers, which is carbon dioxide or erbium, there's radio frequency, and more recently there's the HIFO. So these energy-based devices, the idea is that they remodel the collagen, and whereby they rejuvenate the vagina. This is the concept. I'm not saying that how it works or it does work. I'm just saying this is the concept, that there's remodeling of the collagen, and it helps in rejuvenating the vagina. Now, there has been some studies to show that it does help to some degree in vaginal laxity and mild prolapse. There has been randomized trials showing it does help in vaginal atrophy. There are small studies showing some improvement in urinary incontinence. Now, unfortunately, all those studies are quite small, and they're lacking the long-term success rate. Now, they can be useful. However, the only, so here, but we don't have long-term studies to prove 2 things: efficacy and safety. Now, as you know, that FDA and the Saudi FDA has withdrawn all those energy-based devices and stopped using them until studies are there. The question is that, is there any harm being done? Well, you know, I do a lot of vaginoplasties, and I've published recently a study on 3 patients underwent vaginoplasty after having failed laser. So they had failed laser and they did not improve, and I've done vaginoplasty. And in those 3 patients, I found that there's significant scarring, there's excessive bleeding, and their surgery was really difficult. So this raises really the question of, does laser or radiofrequency, does it cause scarring? So if women do get pregnant afterward, are they going to have worse tears? Or if she would have surgery afterwards, surgery is going to be as successful as if she did not have. So these kind of information are not available. So we're really waiting for long-term studies, safety studies. However, short studies have shown that they might be effective. I'm not advocating to use at all, because there has been warning not to use by SFDA, Ministry of Health, and FDA, other bodies around the world. Until they approve it, I do not recommend their use. However, I wanted to touch base on it. So with that, I think I've covered most of the issue of urinary incontinence. I apologize if I was quick, but it's a long topic. Perhaps we can have another presentation later to cover more specific or make a more focused presentation. So here I conclude by incontinence being quite prevalent with significant impact. History and proper assessment by history is really important. There are effective therapies, and you need to make sure that you've got the right diagnosis before starting therapy, and treatment can improve or cure most patients with incontinence. And thank you for listening and for joining us today.
Thank you very much, Dr. Ahmad. It was a wonderful presentation, and I see already some people are asking questions. So going into the questions, there is a question that stated cough test should it be used with an empty or a full bladder? This was one of the questions. So can you elaborate on that?
Okay, I've got the technical thing. Just a second, please.
Yeah, I'll read the questions for you. That's okay.
Okay, yeah. Tell me the question because I'm here.
Yeah, sure.
The question. I've been logged out. I don't know but that's good. I'm here. I can hear you.
Don't worry. Yeah. In regards to the cough test, how is it performed? Is it on an empty, full bladder, half full? Can you have some word on that?
The cough test.
Yeah.
Okay. So cough test is basically you try to do it with a comfortable full bladder. If basically you want to make sure that the bladder is full, so that if they cough, then there would be leakage through your urethra. Now, if you do it with the bladder being empty, in that case, if you do have leakage with the bladder empty, that's what we call empty bladder empty cough test. With that, it means that there is severe stress urinary incontinence. So if there is leakage with the bladder being empty, that means that it signifies that there's severe stress urinary incontinence. So we generally try to get the bladder to be full, because when you want to get somebody to the exam room, you want to get them one time. You don't want to get them with an empty bladder and then you go, okay, go drink some more fluid and then come back. It's going to take another half an hour, 45 minutes. So it's better. I usually get patients to, after history, are you comfortably full? No. Okay, go drink. I will see another patient and then examine them with a full bladder.
Another question is, does the cesarean section reduce urinary incontinence in comparison to vaginal delivery? And how much percentage does it lower the risks?
This is a tricky question. I think this needs by itself, it needs a presentation by itself. In general, urinary incontinence has higher risk of incontinence and prolapse, general pelvic floor dysfunctions. However, cesarean section does not, I repeat, does not prevent pelvic floor dysfunction. So pregnancy by itself can predispose to pelvic floor dysfunction, or is a risk factor to pelvic floor dysfunction. So to answer your question, yes, cesarean section have a higher risk than cesarean section. However, cesarean section does not prevent completely pelvic floor dysfunctions.
Okay. Another question is in regards to the magnetic chair technique.
Yes.
Can you explain more about that?
So the magnetic chair is a chair that is placed, emits a magnetic field under, usually under the seat. And when they sit on it, it gives sort of contractions. So it gives pulse and stops, pulse and stops. I've tried it myself. I sat on it, and when I turn it on, the muscle contract and I move up with each contraction. So it basically gives pulse to the pelvic muscle to contract and trains the muscle. So that's how it works. They sit down on it for 20 minutes or so. So that's a session, 2 to 3 times a week.
Okay. There was another question related to combining more than one medication when it comes to dosing and using treatment for incontinence. The question is how to combine more than one medicine and dosing.
Okay, so now what I usually do, because anticholinergics are readily available in most government hospitals, and they're cheaper than mirabegron. Okay, so I usually start with those. There are 2 dose mechanisms or 2 doses for instance, for the Vesicare, 5 and 10 milligram. The Trospium, there's the 30 and 60 milligram. So what I usually do, I try one of them, and then if it doesn't work after a month or 2, I double it. So 5 milligram Vesicare to 10 milligram. And then if it doesn't work, then try Trospium, for instance, 30 milligram, and then double it if it doesn't work, or if there are side effects. Now, if there is some improvement on one of them, however, the improvement is not enough, then I would say, okay, how about trying mirabegron as well, 1 tablet, addition to what you're using today. Unless they have significant side effect, they don't want to use any of the anticholinergics, then this combination of 2 medications does have very good results.
I'm going to select some questions that are not mentioned in particular within the presentation, and I'm encouraging everyone, inshallah, to follow up on the YouTube channel to attend for the lecture in that. Another question which is interesting, in patients with overactive bladder with no prolapse and neurologic comorbidities who are refractory to all oral medical therapy, including miravigonon, do you find intravesical Botox or sacral neuromodulation to be more effective as a second-line therapy?
I usually call it third-line therapy, because first-line therapy is the conservative behavioral therapy, pelvic floor exercises. Medication is the second line. So if there are refractory to medications, to combined medication, I usually myself, my preference is Botox, and it's usually magic. Now 60% of women get this magic effect. They improve. They feel that they're really back to normal. They're normal, they don't have anything. And usually it takes like 6 months, 9 months, 1 year, and then it starts coming back again. My colleague in King Fahd Medical City, Dr. Badr Saeed, he does also sacral neuromodulation, posterior nerve stimulation. It has similar effect as well. However, my preference myself is Botox, but both have similar success rate in our hands. So those are women who have failed therapy or double therapy, and they usually go for this line.
Very good. And I think we have a lot of questions. And I think what we can do is we've selected a few of the questions that are coming here. The rest can be put on the channel. And later on, the answers will be answered. What do you think, Dr. Ahmad? Because there are a lot of lectures. Yeah, very good. Very good. First of all, I would like to welcome everyone from joining. I'm going to share with you the links for the upcoming lectures. So please, you can register for those lectures through these links I've shared with you. And you're going to, inshallah, find the lectures on the YouTube channel, inshallah, soon. And I really, really thank Dr. Ahmad Al Badr for his time and all the attendees. I've seen now, mashallah, Dr. Saeed Sari, Dr. Hassouna, Dr. Bamana, and really a lot of beautiful and nice colleagues that I would, inshallah, we're going to wait for their lectures, inshallah, soon. So thank you very much. Thank you very much for this. And I really hope to see you soon, inshallah. Thank you, Dr. Ahmad.
Haytham, thank you so much for having me here. And thank you. I'd like to thank everybody who joined us. And I think the other urogynecologists are here to monitor me, make sure that I'm doing well. And I hope I've done well. Thank you so much. And I'm really pleased, and I look forward to being with you again.
Thank you very much, Dr. Ahmad. Allah yasadak. Shukran. Thank you very much.
Have a nice
evening. Good night, everyone.
Take care. Bye-bye.